we won't get to all of that today, but we're going to start off really with this first question about why are we facing scarce supply? So I'm gonna, if that's okay, I know some of you folks, I'm glad you're having dinner. Keep eating, keep hydrating. But maybe I'll share a few slides if you are in front of a computer. Hopefully you can see this. Okay, so, and this is, if you think of this, there's so many dimensions to this problem. We're going to try and tackle these 4 questions. And I just want to acknowledge this is very supply side oriented. So there's a whole other dimension. Think of this as different axes of how do we think about the supply in the midst of a pandemic? How do we think about vaccine delivery in the midst of a global pandemic? And then obviously the demand side, which actually is fundamentally a different set of dimensions that we won't be able to cover in this short segment today. But I did want to give you a sense on truly where's the vaccine portfolio since we last spoke in the Aging Well community a few months ago. Number 2, why is the supply scarce and why are the numbers dynamic as we're reading through news reports and press releases, both within the US and globally? A third question that many of you have been asking about, what does this mean that we're seeing variants? And what will the effect be on the vaccines that are now approved and future vaccines that will come through the pipeline? And then what has been the effect of these scarce supply on the numbers that we're able to distribute in the US and globally? So I'll try to do that in about 15, 20 minutes. And then most of the time we hope to reserve for discussion. So just to keep us all updated, this is a great tracker. There's a lot of them out there, but just to remember that we need a diverse portfolio of vaccines. We're in the midst of a global pandemic and we need different platforms because no individual platform will be able to cover billions of people across the globe, everyone that we want to protect. And so in a sense, we need to have a diversified portfolio. And the first generation vaccines that we've been speaking about a lot, there's a reason and rationale why the mRNA vaccines were able to get to approval so quickly because the nature of the platform. But just to keep our ears open, that we're going to be hearing a lot of other news about other vaccines that make it through this process, phase 1, phase 2, phase 3, and all the way to an approved vaccine. I also just want to point out, we have some vaccines that have already failed. And that's an important point because we're going to come back to that about those companies that are now horizontally cooperating with the approved vaccines. So I know many of you know this and everyone's been reading the newspaper as such, just to keep ourselves abreast of the Pfizer BioNTech mRNA vaccine. One of the things I want to stress here is that it's a 30 micrograms of vaccine. So we've been able to see this effect with a very small dosage of the vaccine. And the news of the last 2 weeks, one point that was quite concerning was that Pfizer actually cut the delivery, the number of vials to be distributed to the states. Because if you remember, there's a conversation that we could get an additional dose out of each vial. So what we've just done is, in a sense, reposition the implementation bottleneck. The bottleneck is no longer, am I getting the vials of vaccine, but holy smokes, do I have the right syringe that I need to extract the maximum doses for each vaccine? So the back and forth here politically was that there's actually pressure put on Pfizer that when they're going to make this change, we're now going to give you 33 million vials versus 40 million vials. You're literally going to get less number of vials in each distribution, that they also needed to supply the syringes with the vaccine. Now the syringe company wasn't ready for this, right? You can imagine the raw materials needed for these types of syringes. And we're really looking for this column B here, where it says a low dead space syringe with an attached needle. That's the optimal syringe where we can extract as many doses per vial, and it's a safe and effective syringe to use for adult immunization. So I'm just bringing this up as an example of Pfizer makes a press release, and then another enterprise is now rushing to supply in this dynamic moment. And I know many of you are following the Moderna, which is obviously a local story as well. This is a Cambridge company. The trial was run with many folks in our network here in Longwood Medical Area. There's some differences. Also, just to note that the mRNA vaccine that Moderna's created needed 100 micrograms of vaccine. So that actually means we need to be manufacturing 3 times more of all the raw materials to produce this mRNA vaccine than we did the Pfizer, which was 30 micrograms. And many folks call this like a beginner mistake. that the trials actually showed the same efficacy, and so there's ongoing secondary trials to be run. Will a lower dose Moderna vaccine have the same efficacy? So I'm just putting these questions out there so you'll be aware. These are kind of future clinical data that will come down the pike. And then I think many of you also have been following the Johnson & Johnson press release that came out earlier this week. What is interesting for many reasons, but this is a thermostable vaccine. It's a one-dose vaccine, and it's a non-replicating viral vector vaccine. So it's a different platform for the mRNA vaccines. That's why it took the trial longer to run, because the materials to produce thousands of these vaccines actually took longer to produce. And it actually carries pieces of the genetic material that, while it can't replicate, it provokes your body to respond as well. This data, we don't have all of the data from the trial. So that's why you see the asterisks on the slide here, because while the press release says the vaccine's 85% effective 28 days after vaccination, what's actually remarkable, it's 100% effective against severe disease after day 49. So that means there were no hospitalizations, right? Where the first goal of this vaccine is to prevent you from getting severe disease, from needing to be in the take on a hospital. So quite interesting. Of course, we're all waiting to kind of see all the raw data regarding its effectiveness against each of the variants. I'll speak about that in a moment. So we're waiting for J&J to file the EUA earlier this next week, but quite promising. And the third thing I'll just say about the Johnson & Johnson vaccine, as many of you know, is that the manufacturing process has already begun. There's probably 200 or 300 million doses of the Johnson & Johnson vaccine already produced, sitting in a warehouse, ready to go in a vial. And that in of itself is unprecedented, that we've in a sense begun these clinical trials, gotten through phase 3, and in parallel begun the manufacturing process at scale. And that means we've scaled all of the subsidiary, think of all the ancillary, almost the recipe for each of these vaccines that are different, and how those recipes need to change when you're scaling production to millions of doses. So now we're really truly here. And I think this is a question that many of you have been asking, and thank you. I mean, there's just been an incredible, robust discussion that's happening on many foreign avenues. And I think this is probably the snapshot that I want to give everyone a sense of. This is the moment in time we're in. It's temporary. We are going to be able to produce millions of doses of this vaccine portfolio. But we happen to be in this phase 1 right now of facing a low supply and a high demand of a vaccine to protect the general population, adults around the world who should be protected in this moment of high viral transition. I'm projecting this is dynamic, right? We're going to be in a phase where we actually have high supply and low demand. And every country is facing this type of bullwhip, because what happens when supply is dynamic and demand is in a sense following is that people start stockpiling. They are concerned that they will not receive a replenishment of their supply, or they won't have sufficient supply to receive the second dose to give to patients for a 2-dose regimen. So we have to acknowledge this is the dynamic that we're in. It's going to change. And we've seen that in all the press releases. For example, Pfizer in December said there would be 100 million doses available to the United States. Then there'd be 50 million doses a week later. Then in January, the Pfizer CEO said we'll be prepared to have 1.2 billion doses in 2021. And why I'm mentioning that is that dynamic, and why these CEOs are coming out with this is because they've actually been able to cooperate with their colleagues from other companies. That's why the number is changing. So this week, there's a really incredible set of press releases that came out that may not have hit your transom. For example, Novartis, which is a company that does not have a vaccine unit, will be providing capacity to produce the Pfizer BioNTech vaccine. So that means they're actually like giving up some of their manufacturing capacity that they would use for their products to start producing the mRNA vaccine. Similar, GSK, another large company, Sanofi, another large company. And that means these CEOs that have been sitting at the CEO roundtable together since March have figured out a way to use what they do. They outsource the manufacturing to these entities called CMOs. And they're actually adding capacity to the CMOs so that we don't face a bottleneck based on the capacity being in the wrong place. And much of the manufacturing capacity for vaccines is actually sitting within the EU. literally on the real estate of the EU, and I'll explain why that's important later. But I just want to put a flag up there that it's kind of tremendous to see this level of horizontal cooperation. We need to continue, and we need to maybe inspire and advocate that continues throughout this constraint of vaccine supply. So now, we're at this critical moment, and many of us are concerned when we're watching these viral variants that are emerging worldwide, and they're happening in places where there's high viral transmission. These are countries that have not been able to suppress the virus. The virus is working 24/7. It's using the machinery of our cells to replicate, and in those replications, it's clear we'll see mutations. Most of them don't mean anything clinically, but obviously we're quite concerned with the variants that we're seeing, and we have to acknowledge that there's more to come, that we're going to be facing other viral variants. And that's why we need to, in a sense, have this type of epidemiologic surveillance. Where are the variants coming from? How are we effective? And how do we continue to think about how do we thwart future variants? And I know many of you are following this, what's happening for the variants in the UK, in South Africa, in Brazil. To be honest, they probably shouldn't even be called by their location anymore, because they're literally global variants at this time. And there is a concern from, unfortunately, the variant, for example, in the UK, that it's associated with increased transmissibility. So that means, unfortunately, the virus is able to transmit to more people. One person can transmit to many more. So it's unfortunately a more efficient virus, which is not what we want to see. We don't have full data to understand if it's actually impacting the severity of disease, but that will come out as well. And we're going to see that all the vaccines, when we see the clinical trial data, people will be asking how effective is it against each of these variants and future variants as well. My big picture kind of point here is that we'll have to kind of keep our ears out. Not only is this vaccine effective, but the likelihood that we may be suggesting you receive a booster of a vaccine to cover a variant. And so that also reminds us in many ways that we may receive a dose, 2 doses, and then this may become embedded in your preventive plan with your primary care physician to receive a booster based on changes we're seeing in these variants. So, for example, I think, and thank you, many of you have been emailing about this Moderna, concerns about the Moderna, and will it actually cover the variants? And so it's just tremendous to see what these companies are doing. They're starting already to develop a booster shot tailored to the variants. And so you'll hear information about how well it covers and changes to maybe the second dose and or obviously boosters are coming. So more to come here as well. Similarly, when the Johnson & Johnson data came out, it was assessed not only by how effective is it for moderate disease, severe disease, but obviously also by variant as well. And a concerning result here regarding the South Africa variant, and more to come. We'll wait for all of the data. They'll likely be public early this month. So second critical moment that I think we're all thinking about in our daily lives, and people are thinking about how is the vaccine part of the arsenal of tools we need to suppress the virus? We have to also know that we're likely not going to eradicate this virus. We need to think about how are we going to manage with this virus in our daily lives. And so alongside using protect PPE, masking, testing, physical distancing, how do we deploy a vaccine in the midst of a pandemic? And this is this complex operational moment of how do we vaccinate as many people as we can, not to leave a shot in the freezer, with equity and the complexity of distributing a scarce resource in an equitable moment. And I think that's why we go back to this complex system, because what we've seen, unfortunately, in this low supply, high demand moment is that it has not been an early equitable distribution of the vaccine. First, we're seeing much of the vaccine still remain in the freezers. So these are kind of the numbers from Massachusetts, so doses distributed versus administered. You can also see, and people ask, why are certain states doing quite well? So North Dakota, West Virginia, New Mexico. And I want to first remind us that the doses were allocated proportional to the adult population of the state. So there's functionally just fewer doses going to some of these low population states. An interesting note of West Virginia is they deployed all of their local channels. So they called the local pharmacists, local community clinics to start distributing the vaccine, which is interesting to think about. What does that mean? That, in the sense, trust quote dividend that you have regarding your local providers. Of note, we're still trying to understand this patchwork. What does vaccine distribution and administration look like today? And this is hard. The states have been beleaguered to track, obviously, communicating about the pandemic, understanding the role of PPE, testing, shelter in place, should we open the schools? And now we've asked them to take on the most complex deployment. They do not have the data infrastructure to publicly communicate. And I know many of you are seeing this within the state of Massachusetts. Here's kind of just the snapshot of all the 50 states in Washington, D.C., that there is not a public resource for folks to come to understand the number of vaccine sites, for example, appointment availability being a second bottleneck, and then for us to continuously monitor equitable vaccine delivery. How do we understand the vaccine recipients by age, gender, race, and ethnicity? I have to say, this is going to get better. Even within the first week of the Biden administration and the COVID-19 vaccine data team there, I suspect this slide will be filled in within weeks to time. Second, I want to just share, there's just been a tremendous effort in January to start opening up new delivery channels, large scale delivery channels. So for example, the stadiums that have opened, Gillette Stadium, Fenway Park. I think some of you saw the news from Dodger Stadium. And obviously FEMA has been a tremendous implementer at this point. Even in the last week, this map will light up. What's unfortunate is if we look at this by geographic reach, so I mapped on here with a student, where are all the convention centers and sports venues? Where are all the pharmacies, retail pharmacies, CVS, Walmart, Walgreens, your local pharmacy? And so if you're able to access that within 5 miles of your home, you're in blue. But if it's more than 5 miles, you're in the lighter colors on the slide. And I just want to acknowledge, look at, unfortunately, large parts of the country where people are going to have to drive, get on a public bus, travel a significant distance to get the vaccine. And so we're very much thinking about, gosh, we need to create additional delivery channels, local delivery channels, so that this becomes a convenient part of someone's day. Obviously, especially with the 2-dose vaccine for people needing to come back twice. So I think many of you are following this and kind of where we are with respect to Massachusetts. This is also happening across the state, that we're seeing just tremendous concentration of the supply in our high densely urban areas versus Western Massachusetts. And we have to still acknowledge that these numbers are still relatively low, right? We have about 11% of the state's population covered. So just a few more slides here, but just to remind us kind of how complex and how we need to think about both our vaccine supply and how do we think about time and the value of time, which we have so little of to suppress this virus in this moment. And a really important paper was done by Rochelle Walensky, who's now the head of the CDC, where she modeled with colleagues vaccine implementation, that even those vaccines, if they had modest efficacy, remember our assumption was that the vaccines would have an efficacy of 50%. That was the bar the FDA set. Even if we had vaccines with low or moderate efficacy, we'd actually have reductions in COVID infections and death if they were swiftly, if they with speed delivered to a large population, percentage of the population. And that's why this Johnson & Johnson vaccine is, in a sense, quite promising for parts of the country where this idea of a thermostable 1-dose vaccine may be able to cover parts of the population that may not swiftly be able to access these mRNA vaccines. And just reminding us why it's important to have both a portfolio and to think about how do we operate with both speed and equity. So we've been thinking about this problem in many ways. I've been describing the complexity of supply, which will be increasing, but we're concerned that the dynamics of demand, as we start reaching out to different populations, will actually decrease over time. And we think about vaccine demand and vaccine confidence as a spectrum. We understand why many are saying, I'm going to wait and see. What is my neighbor decide to do? What does my healthcare provider advise? What does my clergy member suggest. And with that, we need different and to expand the delivery channels to meet those needs as demand lowers and supply rises. And so we're truly thinking about, gosh, what does this look like at the last mile? Think of it as like Q3 and Q4 of this year, where we'll need your primary care provider to have access to the vaccine to give it to you if you're in the clinic, for example, to have mobile delivery channels, community organizations, homeless shelters, food banks, other ways we can reach folks. And this example is actually how we deployed the smallpox vaccine. The vaccine was actually given at school. And in New York City, in 1 week, they vaccinated 6 million children. So in many ways, we have to use those examples. We know how to do this not only from previous pandemics, but previous mass vaccine distributions, and we're eager to bring and prepare those delivery channels ahead. And second, we could just talk about just this slide for quite a long time. And you know, there's a lot of expertise on this call that I'm hoping to do part 2 and part 3 of the session over time to think about, where is trust in our healthcare system today? Who are our patients and populations leaning to, asking questions and need answers from? And it's quite clear, if we think of trust and reach, your primary care physician, the individual who takes care of you, is someone that has a high trust quotient. They've been taking care of you longitudinally and will be helping you prevent future diseases. And we know in this moment, people have had fewer moments where they've been able to access their provider in person. But how do we create this moment that the COVID-19 is part of the discussion of how you're thinking about preventative health with others? And you can kind of see this spectrum here. I just want to acknowledge that this is different for different populations, and it's different by different age groups. And that's why what we're thinking about, how we generate demand and confidence in the vaccine needs to look different, considering the spectrum of vaccine confidence in subpopulations. Also, this has geographic implications. This is a wonderful analysis by a friend at MIT about, will your neighbor get the vaccine? You can see Massachusetts high up in that corner in deep blue. So yes, many Massachusetts residents will likely get the vaccine. You can imagine the sub-pockets of hesitancy even within Massachusetts, but you can also see these states where there's some of the states that have literally all green. There's not a blue spot in there. And the different detailing work it's going to take to establish delivery channels and establish interest in the vaccine ahead. And I just want to acknowledge, and many of you, several of you have asked some excellent questions that I have not been able to fully answer about different dosing regimens that have been discussed. For example, a single dose in one jab should remember that 100 micrograms versus 30 micrograms of Pfizer and Moderna. Why can't they just give me the entire dose in one shot? Or should it be spaced out differently? So the CDC came out to say you can space out the vaccine, for example, within 6 weeks. The NHS is even seeing a longer time period. Or should the single dose be divided into 2 half-dose jabs, or a single dose of one vaccine followed by another vaccine? And this list is going to change. You're going to hear about different formulations, different ways people are thinking about it, because we're in the midst of scarcity. That's why we're seeing all the scenario planning, because there was a lack of confidence in December of how much supply would we have. The state was getting 3 days notice of the supply it would receive from Operation Warp Speed. So a lot of brain trust was being spent. Gosh, how do we stretch out that supply? Like when you only have 12 eggs and you've got to make 4 cakes, right? Like many people are saying, gosh, I'm not going to ask my neighbor for another egg. I'm going to figure out, how do I use these 12 eggs? But I want to just acknowledge that this discussion not only is going to change, but if supply is sufficient, we'll likely assume and will follow the guidance from the clinical trial in the short run. And I think it poses a whole set of questions that I can imagine us at Kiddush talking about if we were sitting at those round tables together. So really, truly the moral questions here that have surfaced. So how do we balance the complex needs of a vaccine that protects an individual versus how do we protect population health? How do we maximize the number of beneficiaries versus maximizing fairness and protection of those that are high priority, those that are at risk of death from COVID-19? And then in many ways, this complexity that I know we're all facing in our community at TBZ and within the United States is that we've been deploying vaccines in the United States where there are certain countries that will not even receive a vaccine in this calendar year. How is it that one country, for example, Canada, has procured 4 times more vaccines than they have of a population? The United States, the UK will, in a sense, be able to vaccinate a large majority of the public versus others being able to receive the vaccine at all. And this is a graph I know many of you have been looking at regarding the doses administered per 100 people as of the end of this month. And it's a very mixed demonstration of countries that have been able to procure the vaccine, distribute it, and allocate it. And also, we could spend hours on the slide discussing why each country has been able, is in the situation that we're within. There's tremendous lessons to be learned from Israel and how Israel has deployed the vaccine and responded like this is a bioterrorism event. They've used some of the same information infrastructure, their ability to communicate with the general population, how they're able to respond when there's additional doses and move those doses around. And there's much to learn about it. Israel is also set up as a country to respond with immediacy and to ensure those who may not be able to access it receive it. This list is quite interesting. You can kind of question, and Daniel and I had a conversation about Canada. Typically, you think Canada with a centralized health system would have actually had more doses allocated at this time. So we'll continue to all learn and see these patterns and what can we extract as we deploy the vaccine in our local communities. So I'm just going to end here that, and many of you are kind of thinking about this and leaders in this space, that the vaccine is one tool in our toolkit right now to suppress this virus. The virus is working 24/7. And we need to be doing all of this well, ensuring that you have access to better masks, better ventilation in our school systems, in our community centers, better filtration, better tests, and obviously better support of our vulnerable communities. So I just wanted to take that step back out, that this is our responsibility ahead. It's a highly active combination of tools to suppress this virus and to help us protect the most vulnerable in our communities. So Rav Tiferet, I'll pass the baton back to you so we can start a discussion.
Wow, thank you so much. That was amazing. Whew. Okay, so we have a little time now to open up for general questions if there was something that you didn't understand about the slideshow. And like I said before, and I also, like Rebecca said in her slideshow, the trust quotient is highest with your primary care physician, with your own healthcare practitioners, and they know you the best. So if you have very specific questions, then you should reach out to them. And that's, much easier now these days with these healthcare portals. And also, if you are over 75 and interested in getting some help in figuring out where do you get the vaccine, the Chesed committee just sent out an email that they are absolutely ready and willing to help you figure that out, navigate that system. So you should definitely check your email, and I'll find the information and post it in right here. So are there any general questions? You can put them in the chat. And if you cannot put them in the chat for whatever reason, raise your hand and I will unmute you. All right, I see one question, Laurie. Whoop. You're muted still, Laurie. There you go.
That better?
Yes,
Okay. I wanted to ask, my sister was saying that you shouldn't take Tylenol when you get the shot. That it de-affects it, or whatever, however you say it.
Lori, that is a great question for your primary care provider. Well, great question to ask before you get the vaccine.
I already got it. That's my problem.
Oh, yes.
So you don't know.
Even more.
I'm here to help us understand the complexity of what's
Okay.
happening. Almost
It's
think
a
of it as like the
different-
complex
okay.
market dynamics. Yes.
Okay.
Hi, Rebecca. Can you hear me? That was fabulous. Just really,
Thank you,
really
Rebecca.
fascinating and interesting. I did have a question about reading about all these variants, and you mentioned that, and to me as a layman, it sounds somewhat terrifying. And at the same time, I've been fascinated by the fact that these people who made the mRNA vaccines, Moderna and Pfizer, were able to so quickly, essentially in a matter of days, figure out their vaccine. And they're sort of making perhaps grandiose statements like, oh, we can easily modify, but what does that really mean? I know that they can design something new very quickly. But how long would it take, and can they really adapt quickly enough to actually, can they get approval to do it and then get it out to people that quickly? Is that workable?
So obviously I'm not, in the Moderna shop to say, absolutely, Tom, but I'm very confident. Yes, I'm very confident in the mRNA platform of how it'll be able to respond. And you're absolutely right. If you look at the calendar, I have this amazing calendar, how quickly the virus was sequenced, and the team at the NIH was able to produce this first mRNA vaccine, right? And then work with Moderna. So in a sense, we are the basic, almost think of it as like the architectural plans are there to then be able to respond and then produce, for example, a booster or a new form of it, and then run into a clinical trial. That's why the mRNA vaccines, in a sense, are weeks, sometimes months ahead of the other platforms in the trial, because they can actually produce the structure and manufacture it in thousands of doses to get it through a clinical trial. It's actually a simpler, more purified manufacturing process that will help us then, okay, we might need to take that form off the market, for example, or you might need to receive a booster within the mRNA platforms. The second is that this horizontal cooperation with, for example, Novartis and others, where we'll start seeing that the bottleneck may not even be the actual design of the vaccine to respond to the variant, but actually the manufacturing of so many different mRNA vaccines, because each countries will probably need to procure different types of vaccines depending on the variants that they're facing.
Okay, we have a question from Judith. What about families where some people are vaccinated and others are not? Can we have a Seder together?
Judith, well, first, it's lovely to see you, and that is a very complicated question. So right now, as you know, what we're advising, even after you receive the second dose, even if we know that you are protected, Judith, with the vaccine, that you can transmit. It's likely that you're transmitting less of the virus, but we don't have the data to say the person who's received both doses of the vaccine and has protected themselves, they likely could unfortunately be an asymptomatic carrier to their loved ones at the Seder table. So, last year is a very painful moment, and my mom's here on the line when I had to call my mom to say, Mom, I don't think we're having Seder in person. And I have to be straight up with you. I would not recommend having Seder in person when you have vaccinated and non-vaccinated folks at the table. But I would recommend talking to your primary care provider. But I'm saying this out loud just to protect our community here. I know folks are planning, and thank you, Rob T. Ferret ran a beautiful second Seder by Zoom last year.
I saw a hand from Max.
Hi.
Hi,
So that was one of my questions initially too. Actually, is that I'm hearing from a lot of people that they're speaking and behaving as if basically once they get the vaccine that they're kind of virus proof and that they can just behave as if nothing is wrong and that COVID has just gone away for them. So I was wondering if you could speak to that about, like, is there like a tipping point, like once we have this percentage of the population vaccinated, that maybe it'll get back to normal, but I was wondering if you could speak to like my understanding of the vaccines that we have now and the distribution that we have now is that even once you are vaccinated, you should still live your life and behave as if you have not been vaccinated, and just to protect yourself and to protect others until we hear otherwise. Is that
that's correct, Matt? That is correct. We don't have longitudinal data on the vaccine's ability and duration. It looks very good. It looks incredibly promising, right? That it'll establish your immunity over a long time, hopefully a year plus. But we don't have that data to provide, national or global guidance at this point. And so the idea is continue wearing masking, continue practicing physical distancing will help us protect us all. And remember, it actually decreases the transmission of the virus. That's our goal as we're protecting you. The more we can decrease viral transmission, the less variants we're going to see. And then we'll be protecting via indirect protection as well. So literally, when you're wearing that mask as someone who's received the vaccine, for example, you're protecting others by wearing the mask in case you can transmit. And as we're all watching these variants, we don't know enough, but since several of these variants they are likely transmitting at a higher rate, wearing that mask is incredibly effective at protecting your loved ones.
Thank you.
Hi, I'm sorry, I came in late, so if you've already addressed this, have you spoken at all about the guidance of wearing 2 masks now rather than 1?
You know what, Rachel, I didn't speak about that. I've been just focusing on like the dynamics of supply of the vaccine. That's probably a whole other conversation we could have as a community about 2 masks. So I'm probably going to just set that aside. Rob T. Ferret will come up with a calendar of other pieces, but the evidence is evolving and the role of different types of masks, which many folks on this call and others have been looking at over quite some time now. And I think we're going to see the guidance changing. It's been changing, week by week as well. Let's plan that for another session, Rob T. Ferret.
Are there any other general questions? Okay. All right. So we are so blessed to have Rebecca here sharing this with us. And she is for sure a source of wisdom and a wealth of information. And like I've said, if you have any follow-up questions about how to get the vaccine for yourself or for a family member, follow up with your primary care physician. As tempting as it might be to follow up with Rebecca, she is busy saving the world and trying to save it for our sake and for our children's sake and our grandchildren's sake. And if you need some help or you have some questions, reach out to the Chesed Committee. They are ready and willing to be of service. And so I just want to again thank Rebecca for giving us this time. Thank you so much, and putting some of our minds at ease. This was absolutely fantastic. And before you run off, I just wanted to share my screen because there is a related event coming up that I think you'll be interested in. Hold on a second. My 10-year-old computer is moving a little slowly. Hold on. Here it is. Perfect. Okay. We're having a Kiddush Talk. As you know, we're having a Kiddush Talk now every month. And we are blessed to be welcoming Dr. Christopher Willard to discuss You Are Not Alone, Strategies for Coping During These Difficult Times. And that's coming up February 13th, right after Shabbat services. And this is, of course, in honor of Jewish disabilities and Jewish Disabilities Awareness and Inclusion Month. And so you can see here, our fantastic inclusion committee is honored to welcome Dr. Willard, and he will share insights and tools for managing the feelings of anxiety, loneliness, depression, and the fear that so many of us are rightfully experiencing in these days. So join us for this Kiddush Talk, and it'll be fantastic to be together again and hear some coping methods for us. All right, so thank you all so very much, and Shavua Tov, have a beautiful week, and I look forward to seeing your faces at events during the week.
Thank you.